Welcome, everyone. We'll get started in just a few minutes here. This is a great audience. Feel free to put into the chat who you are and where you're responding from or where you're participating from. We'll get started in just a minute. Liking all the positive chats and energy and spirit that's coming through in the chat. So welcome, everyone. Great, so we've got a really good number, and I want to welcome you to our webinar. This is the Inter-CFAR collaboration for HIV research in women, sponsored by the Center for AIDS Research. And we're really, really fortunate today. Myself, I'm Kate Powis, I'm from Mass General Hospital, and Maria Alcaide is from University of Miami, and we have the pleasure today of hosting Dr. Moffinson, who's a board-certified pediatric infectious disease physician who received her medical degree with honors from Albert Einstein College of Medicine. She served as Assistant Commissioner for Communicable Disease Control at Massachusetts Department of Public Health for 4 years before being recruited in 1989 to Eunice Kennedy Shriver National Institute of Child Health and Human Development to direct pediatric and maternal HIV and related infectious disease research, including tuberculosis in children and pregnant persons. And as many of you likely know, Dr. Moffinson helped design and lead the landmark Pediatric AIDS Clinical Trials Group 076 study. At the time, a really bold and controversial randomized clinical trial where pregnant women were randomized to receive placebo or AZT, and the infants were similarly randomized to receive placebo or AZT prophylaxis. And although Dr. Moffinson faced harsh criticism during the course of the study, she persevered, and the study demonstrated a 70% reduction, nearly 70% in vertical transmission. Really informing health policy globally. And after a 26-year career at NICHD, directing impactful research on the prevention and treatment of pediatric and maternal infections in the US and globally, she retired, but continued to impact women's health. For example, she serves as a senior HIV technical advisor at the Elizabeth Glaser Pediatric AIDS Foundation, where she's involved in research evaluating the implementation of many of the studies that were actually performed at NIH. She also serves as a consultant to the World Health Organization on safety of drugs to treat HIV, hepatitis, sexually transmitted infections, and TB in pregnancy. Dr. Moffinson has moved the field of HIV forward both for pregnant women living with HIV and for the pediatric population as a leader in both research and policy on the world stage. And today she's going to focus on key science about women's health presented at the 2025 CORE meeting held last month. And as she's presenting, if you have questions, feel free to put them into the chat. But with that, Lynn, thank you so much for being with us today, and over to you.
Okay, let me get the slides up. And do we have the slides? Yes.
Perfect.
Okay, great. Well, hi, everybody. This says selected pediatric and pregnancy, but I'm going to focus really on pregnancy and women for this particular webinar. So I'm going to start talking about pregnancy, antiretrovirals, and HIV testing. So this first abstract is from an observational study that was nested in a malaria prevention trial in Gabon and Mozambique in 2019 to 23. And they collected samples from 99 HIV positive pregnant women who had a viral load greater than 400, so were viral failures, at their first ANC visit, and they genotyped them for drug resistance. So out of the 99, 39 or 39% had one or more HIV drug resistance mutations. And this table compares those with drug resistance versus no drug resistance mutations. Women with drug resistance mutations were older. And in the red box, you can see a higher proportion were on ART at baseline. So at conception, 64 versus 22%. And dolutegravir was the most common regimen being received. This shows you the types of mutations that were observed, primarily NNRTI mutations in 36%, integrase inhibitor mutations in 6%. This shows you the type of integrase inhibitor mutations with the major mutations shown in red. So 2 of the 6 with integrase inhibitor mutations had major mutations detected. So the prevalence of drug resistance was high in these pregnant women with viral failure. However, integrase inhibitor resistance remained relatively low, but do note that in the 2 women with viral failure, there were major integrase inhibitor resistance mutations found, and they call for continued surveillance of drug resistance. This next study comes from Elaine Abrams and her colleagues in South Africa in the study called ORCID. This involves over 1,900 pregnant women, 42% HIV positive on dolutegravir treatment, 58% without HIV, enrolled in antenatal care in an observational cohort, mean 28 years, mean age, gestational age at enrollment 14 weeks. And they compared outcomes in HIV negative to HIV positive women, and in HIV positive women by whether they were on dolutegravir at enrollment, switched from efavirenz to dolutegravir, or started dolutegravir during pregnancy. So they had birth outcomes in the majority of patients. Miscarriage rate was 3%, stillbirth rate was 2%, and they had over 1,700 live births. And pregnancy losses, miscarriage, and stillbirths were similar in HIV positive and negative women. So this shows you the multivariate analysis of birth outcome by various categories. Overall, preterm delivery was 9%, low birth weight 12%, small for gestational age 13%, large for gestational age 12%. So in the red, you can see that there was no association between HIV positivity in women on dolutegravir in pregnancy with any of these adverse outcomes. But independently of HIV, obesity in the blue and alcohol use in the purple were associated with various adverse outcomes. So this shows you birth outcome by HIV status and time on dolutegravir. So whether they were continuing dolutegravir, naive and starting, or switched, or HIV negative, and this looks at term, this looks at birth weight, and this looks at size for gestational age. The blue represents normal. And you can see that there is really no difference in preterm low birth weight or gestational age size between the timing of dolutegravir initiation or in HIV negative women. So unlike other studies, there was really no meaningful difference in birth outcomes in HIV positive women on dolutegravir treatment and HIV negative women, and maternal BMI appeared to be the major driver of adverse birth outcomes in this cohort. And just to comment that there have been some other studies of dolutegravir treatment in HIV positive women that actually have shown some difference, not necessarily major, but some difference from HIV negative women. So that makes this study a little different. So this is a PK study in HIV positive women and HIV negative women to evaluate whether there are drug-drug interactions of the implant or DMPA injections on dolutegravir treatment. So there was 140 women, 70 women were starting the implant, 70 women were starting DMPA, and they were either HIV positive or HIV negative, 35 in each group. And this just shows you an outline of the study timeline. So if we first look at LNG AUC, you can see that there was slightly higher AUC in HIV positive women on dolutegravir than HIV negative. HIV positive women in the little black dots and HIV negative women in the open dots. For methoxyprogesterone, we see that there's really no difference in AUC. They looked at dolutegravir concentrations that were consistent across the arms with no change before or after the contraceptive administration. So they concluded there's no clinically significant drug-drug interactions. Dolutegravir doesn't reduce contraceptive levels, and contraceptives do not reduce dolutegravir levels. So this is a study from Canada. They reviewed all live births to HIV positive women in 22 sites in Canada, accounting for 95% of births in the country. Of over 1,200 pregnancies in HIV positive women, 161 or 13% received bictegravir-based treatment. And you can see in the chart that this increased over time, and most of the women were receiving the bictegravir prior to conception, and most continued during pregnancy. So this looks at perinatal outcomes by timing of bictegravir exposure. People who were on preconception, people who discontinued when they became pregnant, or people who started during pregnancy, looking at preterm low birth weight, SGA, birth defects, and perinatal transmission. And you can see perinatal outcomes in the bictegravir users did not differ by timing of bictegravir initiation. So this looks at perinatal outcomes comparing people on bictegravir to those who were not on bictegravir. So you can see that being an indigenous population and maternal risk category of IDU were both associated more commonly with bictegravir use than non-bictegravir use. And also preterm delivery was significantly more common with bictegravir use. However, when they did a multivariate analysis accounting for all of this, you can see that IDU and maternal viremia near delivery were associated with preterm delivery, but ART exposure, bictegravir versus non-bictegravir, was not. So this is pretty reassuring data on bictegravir use. This was an interesting model-based meta-analysis of population PK of ritonavir in pregnancy. It used data from 11 arms of IMPACT 2016 that used ritonavir as a booster for lopinavir, darunavir, atazanavir with or without tenofovir. So this looks at simulated ritonavir levels over time with gestation. So the green represents postpartum, and the red and blue represents the second and third trimester. So a one-compartment structural model best described PK. And if you compare pregnancy to postpartum, pregnancy was an independent predictor of apparent clearance and volume distribution for ritonavir, resulting in lower ritonavir levels in the second and third trimester in pregnancy. And you can actually see that with these lines reflecting the median. There's postpartum and there's during pregnancy. So they also simulated a AUC during pregnancy, and a 100 milligram daily dose of ritonavir had a much lower AUC, 3.85 during pregnancy compared to 7.1 postpartum. So based on the established relationship of ritonavir levels with CYP3A inhibition, one would think that CYP3A metabolic drug clearance would be significantly increased, and hence ritonavir boosting capacity lower during pregnancy due to these lower ritonavir levels. So pregnancy significantly increased ritonavir clearance with an 84% increase in clearance, 127% increase in volume of distribution compared to postpartum. And these decreased ritonavir exposures are predicted to lead to a 1.8-fold reduction in ritonavir-mediated CYP3A inhibition, and hence to reduced boosting of PIs by ritonavir, suggesting that dosing requirements of ritonavir or the boosted substrates may need to be altered during pregnancy. And this reflects the issue of whether or not darunavir needs to be given twice daily versus once daily during pregnancy. This was a randomized trial that looked at comparing standard of care versus distributing HIV self-test kits versus home visits, 5 home visits, 2 before, 3 after delivery, by a lay cadre of trained community healthcare workers. And you can see a description of the study here, the resource book and key messages. This shows you an outline of when they did assessments and when they did the HIV self-testing distribution. And this down here gives you a more detailed description of what these home visits involved. So they included pregnant women who were greater than 15, less than 36 weeks of pregnancy, and a stable relationship, and had not yet been couple tested for HIV. They included some HIV participants as well. 2/3 of the participants were women living with HIV. So women and men were randomized to home visit standard of care self-test kits with HIV positive and HIV negative as shown, and retention through 12 months was really pretty good, between 79 to 90%. So this looks at couple HIV testing, comparing standard of care self-test in orange and home visits in purple. And you can see that couple HIV testing was significantly increased with both self-test distribution and home visits. Couple skills, as shown here, significantly increased with home visits compared to the other 2 arms. HIV testing and new HIV diagnoses significantly increased with home visits compared to the HIV self-testing. Healthcare use like ANC visits, facility delivery, postpartum care, that was similar between the arms. But importantly, maternal viral suppression was significantly increased with the home visits. Of the HIV-exposed infants at 18 months, 2 were HIV positive, 1 in the home group, 1 in the self-test group, and HIV-free survival was 96% and similar between the arms. So they concluded that home visits significantly improved maternal viral suppression. Both home visits and the self-test kits increased couple testing, that the home visits improved couple relationship skills, and suggested that strategies to scale up this approach would be warranted. Moving on to pregnancy and other infections. This comes from a PrEP study, PrEP-PP in South Africa, enrolled over 1,200 HIV-negative pregnant women over 15 years at their first ANC visit with a mean gestational age of 22 weeks. And they did diagnostic testing for chlamydia and gonorrhea with a point of care test early on and then a lab-based test a little bit later. So this looks at whether there was delayed treatment, immediate treatment, or no treatment. So the prevalence of chlamydia and gonorrhea at enrollment was 28%, 24% chlamydia, 8% gonorrhea, 54% got immediate treatment, 34% delayed, 12% no treatment. And when you compared lab-based testing versus point of care, you can see that the immediate treatment group was much more likely when a point of care test was used. This looks at pregnancy outcome by time to treatment status. So we have no STI, delayed treatment, immediate treatment, untreatment. And when you look at the composite, you can see the outcomes didn't differ by time to treatment. But importantly, when you look at pregnancy loss, either miscarriage or stillbirth, these were significantly increased in women with untreated chlamydia or gonorrhea, whether you were comparing any treatment to no treatment, a 4.6-fold increase, or no STI versus no treatment, 3.89% increase. So point of care testing increased the likelihood of having immediate treatment, no surprise, and untreated gonorrhea or chlamydia was associated with an increased risk of pregnancy loss. So this now moves and looks at curable STIs, similar STIs, within the HPTN 084 CAB PrEP study. So this is over 3,000 uninfected women enrolled in HPTN 084 comparing cabotegravir versus oral PrEP. And they were tested and treated for chlamydia, gonorrhea, and trichomonas at baseline and then every 6 months. 28% had an STI at baseline, most commonly chlamydia. So this looks at STI burden at baseline in blue, incidence in yellow, and STI recurrence in green. And you can see there was a high incidence of STI, 35%, STI recurrence in 15%, and one or more concurrent STIs were seen in 5% at baseline and 9% during follow-up. When they looked at correlates of STI incidence during the study, STI incidence was significantly higher in younger women, women with no or primary education, the purple box, and single, and women not living with their partner in the little blue box. There was no difference in CAB efficacy by STI status. The hazard ratio was 0.08 with women with STIs, 0.14 in women without STIs. So there was a high rate of STIs in HIV uninfected women receiving PrEP and incidence as well. So this shows the importance of STI screening at PrEP initiation and during follow-up visits. This is using data from the Global Fund procurement data, looking at trends in dual test HIV syphilis test purchase between 21 and 23, and an analysis of country-reported data on HIV and syphilis dual testing policy and coverage using the Global AIDS Monitoring Platform. So this is the Global Fund data showing a 192% increase in dual test procurement between 21 and 24, going from 7.6 million tests in 19 countries to 21.8 million tests in 28 countries. This shows you national HIV and syphilis testing coverage in pregnant women in ANC in all reporting countries, in countries that adopted dual testing in ANC and countries that did not have adopted dual testing in ANC. And you can see HIV testing in green, which is pretty similar across the groups, and syphilis testing in orange. So we see HIV testing is high, but pregnant women in countries that reported dual test uptake were 58% more likely to be tested for syphilis compared to pregnant women in countries not using the dual test. That's comparing this here. So they then looked at 3 countries, Uganda, Kenya, and India, and looked at progress towards testing coverage as they implemented dual testing. And you can see in Uganda, there was a 51% increase in syphilis testing, 48% in Kenya, 137% in India, and the gap between HIV testing, which is these little green boxes here, and syphilis testing in the blue, fell from 20 to 39% to between 4 to 10%. So they concluded countries should consider introduction and further scale up of dual HIV syphilis testing to achieve global syphilis elimination goals. This study looked at risk factors for incomplete treatment of syphilis in pregnant women on oral PrEP in the SCOPE PP study in South Africa. It was an observational study of 750 HIV-negative pregnant women looking at oral PrEP in pregnancy. 57% were on PrEP at baseline. and they reviewed medical records regarding syphilis testing and treatment. So this shows you the prevalence of overall syphilis positive tests and the prevalence of prior versus active syphilis. So syphilis was pretty prevalent, 11% positive test, 5% active syphilis. Risk factors for active syphilis included younger age and alcohol use in pregnancy. So receiving complete treatment among women with active syphilis was only 59%. Risk factors for incomplete syphilis treatment included older age, the relationship unmarried or not cohabiting, and sexual activity during pregnancy. 3 infants were diagnosed with congenital syphilis. The mean gestational age of the first positive syphilis test was 22 weeks, and in 6% it was detected less than 4 weeks prior to delivery. And as I said, 3 infants were diagnosed with congenital syphilis. So they note that syphilis testing should be an essential part of a package of HIV prevention for HIV-negative women seeking PrEP, particularly if they are pregnant. And interventions, of course, should include partner testing and treatment and assurance of complete treatment for syphilis in pregnancy. Congenital syphilis is a completely preventable infection. This is an interesting study from CDC that looked at the treatment for syphilis. So the recommended treatment for late latent syphilis or unknown duration in pregnancy is 3 weekly doses of benzosine penicillin G. So the intervals between the injections is supposed to be 7 days. And prior studies have shown that congenital syphilis is no more common if you do 7 days compared to 6 to 8 days. So you have a little bit of ability to be flexible here, but there were no studies of 9-day intervals. So they used CDC surveillance where mothers had late latent syphilis in pregnancy and looked at congenital syphilis. So they divided the dyads into 3 groups: adequate treatment, defined as 6 to 8 day intervals, treatment where at least 1 9-day interval, and no or inadequate treatment. Congenital syphilis was defined as per the box, and there was no difference between these groups in maternal HIV status, RPR level, prenatal care, or gestational age at syphilis treatment. And this shows you the treatment group, the number of dyads, the number of infants with congenital syphilis, incidence, p-value, and odds ratio. So the risk of congenital syphilis was 3.7-fold higher comparing 9 days to 6 to 8 days. And the risk of congenital syphilis is highest with no treatment, but when you compared the no treatment to the 9-day interval, that was not significantly different. So this suggests that you increase the odds of congenital syphilis if you extend the time between the injections more than the 8 days. And they note that a randomized trial evaluating this is unethical, so awaiting a larger data set, clinicians really need to avoid intervals outside of 6 to 8 days between the injections. So this comes from the ORCID study again, and I believe, I can't read the top very well. It's looking at TB. Okay, this is TB incidence. So this is over 1,900 pregnant women, 42% HIV on dolutegravir, 58% without HIV, enrolled in antenatal care. Median duration treatment was 58 months, most of these women on preconception. Only 7% had CD4 less than 200, 89% had viral load suppression, and TB prevalence at conception was 0.4%. So they're looking at postpartum follow-up through 24 months. So this looks at TB incidence rates by HIV status, HIV positive versus negative, and pre-pregnancy BMI, and this did some modeling. So if we first look at TB incidence and compare HIV positive versus HIV negative, you see TB incidence was significantly higher in the HIV positive women on dolutegravir treatment, and that was true regardless of CD4 count. But if the CD4 count was less than 200, or if pre-pregnancy BMI was less than 18.5, TB incidence was substantially higher. So despite most of these HIV positive women being on treatment and suppressed, TB incidence remained higher than in HIV uninfected, and that was associated with a low CD4 count and being underweight. This then looked at dolutegravir PK and viral suppression comparing 1-HP versus 3-HP. So 3-HP is 3 months of weekly INH and rifapentine. 1-HP is 1 month of daily INH and rifapentine. And while giving INH for 6 months preventive therapy, it was suggested from the APPRISE study that this should be deferred until postpartum due to adverse events in pregnancy. These shortened, better tolerated regimens have not yet been studied in pregnancy. And we know that pregnant women have a lower dolutegravir trough level, as shown here, than non-pregnant adults, but while dolutegravir levels are still therapeutic and don't require any dose modification in pregnancy, no studies have evaluated dolutegravir PK with rifapentine in pregnant women. So this was a PK and safety study in 50 pregnant women on dolutegravir who were virally suppressed, and they're giving some preliminary reporting. This shows you the study design. There were 25 women in each group. So if we look at day 1, pre-rifapentine, there was no difference in dolutegravir levels, this is dolutegravir concentration, between the 1-HP and the 3-HP arms. But by the time you get to day 17, you can see there are significant differences in dolutegravir levels compared to day 1, and comparing 1-HP, which is daily, versus the 3-HP weekly arms, with the daily 1-HP lower levels having lower dolutegravir levels and higher clearance. And then there were 2 patients, 1 per arm, with levels that were below level of quantification, but they had adherence issues. And then going out to day 52 for 3-HP, we see that the dolutegravir levels have remained stable in the 3-HP arm. So given that good dolutegravir therapeutic levels were maintained despite increased clearance, the question then was, could once daily dolutegravir be given with 1-HP and 3-HP during pregnancy instead of BID dolutegravir? So they did some modeling simulations, and this is 1-HP looking at dolutegravir, and below target is here in the kind of orange, and here's the 3-HP. So the answer here is no, levels go below the target. And the answer here was 3-HP is possibly. So they concluded in pregnant women, 1-HP or 3-HP with BID dolutegravir give you trough levels that are good viral suppression, assuming there's BID dolutegravir adherence. And in simulation, BID dolutegravir continues to be required if you're giving daily 1-HP during pregnancy. But in simulation, once daily dolutegravir appears to be possibly able to be given during pregnancy using weekly 3-HP, and they're currently evaluating this in an additional 25 women pharmacokinetic study. Moving to hepatitis B, this was a study from Asia, and we know that birth HBIG is recommended for prevention of hepatitis B transmission, but cost, cold chain, and storage limit availability in low and middle income countries. And we also know that if you give tenofovir or TAF plus HBIG and vaccine, it prevents pretty much all mother-to-child transmission. And the question being asked here is HBIG needed? So in this study, it was a single arm. All mothers got tenofovir. And if the mothers showed an adequate viral response, no HBIG was given. The endpoint was 6-month infant HBV HBsIg. And the hypothesis was that the risk of infection would be less than 2%, which is the historical levels with HBIG. So they found that there was a tenofovir viral response in most, but not all, with 93% being less than 200,000 by delivery. There was no evidence of lack of safety. Of the 423 pregnancies with satisfactory viral response and no infant HBIG tested at 6 months, 4 infants had confirmed infection at 6 months. One of these 4 mothers had a high viral load. So it gave you an upper confidence interval of 2.15, which was above the 2% hypothesized. So they conclude that HBIG is important to provide early intervention before active vaccine to prevent established liver infection. And it's especially important if the infant is exposed to breakthrough hepatitis B virus, if maternal tenofovir is defaulted. Moving on to dual antiretroviral therapy, and this is particularly important because the WHO guidelines are being revised, and they're considering both dual dolutegravir 3DC, but also the use of injectable long-acting drugs. So this was a study that used PBPK modeling with virtual cohorts to evaluate what happens if a woman decides to stop LA-CAB rilpivirine early in pregnancy because they're worried that there's not enough data. So they looked at the predicted tail phase PK of both drugs, CAB-LA in green and LA-rilpivirine in pink, after stopping until 6 months postpartum. And so the tail was driven by the residual drug in muscle depot, which stabilized at steady state levels as shown here. And they looked at the predicted percent with the drug levels that remained above the minimum effective level. So maternal drug levels were above 4 times the PA-IC90 for both drugs in everyone at gestation week 8 when they were stopping, but 0% at delivery. Subtherapeutic levels were present to 6 months. Predicted fetal exposure, cord maternal blood ratio close to delivery were greater than 1 for carbategravir, but less than 1 for rilpivirine. So they predicted that maternal drug levels remained detectable until 6 months postpartum, although subtherapeutic, and we kind of already knew this. This came from using the CPEC model, and they looked at the effectiveness of using long-acting ART in breastfeeding women in Zimbabwe. So they looked at mother-to-child transmission and cost effectiveness of postpartum LA ART compared to standard of care continuing dolutegravir ART postpartum, and they looked at women with and without viral suppression at delivery. So NVS is not suppressed at delivery, VS is suppressed at delivery, and these were their base case model input. 6 months suppression being 63% with, if they weren't suppressed at delivery, 78% if they were suppressed at delivery, and assuming based on published data, not in pregnancy, that you would see increased suppression with LA-CAB and potentially increased engagement of care. They did some sensitivity analysis and defined cost effectiveness as a ICER as less than 800 per year life saved. So this is the number of infant infections averted based on CAB rilpivirine efficacy, postpartum vertical transmission risk, care disengagement, and with the base case assumptions, LA ART compared to continuing standard of care decreased mother-to-child transmission and averted 160 infections per year. And if postpartum care disengagement was decreased by 75%, this increased to averting 450 infections per year. So they then divided it up and looked at women who were not virally suppressed at delivery, which is a small number, and women who were. So if not suppressed at delivery, the red here, increased pediatric life expectancy, decreased transmission. It was more effective than standard of care, less expensive, but would not be cost effective if the cost was more than $276 a year or 6 months suppression less than 68%. However, if you gave it to everyone, those who were suppressed at delivery, the large amount of people, while it decreased mother-to-child transmission, the cost also increased, and LA ART would only be cost effective if it was less than $84 a year. So they concluded that the switch to LAR at delivery for breastfeeding women who have adherence challenges, who are non-suppressed on TLD, reduces infant infection in Zimbabwe and would save money. But switching to LAR at delivery for breastfeeding women with suppression, the larger group, could improve outcomes and be cost-effective only if the cost was less than $84 a year. This was a study that Bill Short and colleagues reported looking at women given LA CAB rilpivirine. There's not much published on this. So this was 23 pregnant people. You can see their characteristics here. 74% started CAB rilpivirine prior to pregnancy and then either continued it or switched. And then 26% started during pregnancy. Of those who started prior to pregnancy, most were receiving bi-monthly dosing. 2 of them changed to monthly dosing. 29% switched off CAB rilpivirine at a median of 7 weeks gestation. Started during pregnancy, they started in the 2nd trimester and all received monthly dosing. And just to comment that we know that cabotegravir PK in pregnancy is fine, but rilpivirine PK in pregnancy is not fine, and that low levels have been described in PK studies. So that's where the concern comes from. So there are high rates of viral suppression, 70% at baseline, 81% at delivery, very, very few with viral load over 1,000. So Bill gave me individual patient data. So this is looking at people starting prior to pregnancy, comparing the bi-monthly dosing in pink and monthly dosing in green. And if you look at HIV viral load at delivery, those who were above 20, so 20 to 200, 2 of the 3 had switched off cabotegravir rilpivirine early in pregnancy. So that does not actually reflect suppression. Also, you can see that viral suppression was similar with bi versus monthly dosing. In those who started during pregnancy, the one patient who had a viral load that was high at delivery had received only 1 week of CAB rilpivirine during pregnancy. Birth outcomes were good, 92% live birth, full term, normal birth weight, none infected. So these preliminary results suggest that CAB rilpivirine in pregnancy, most starting prior to conception, results in high rates of viral suppression and normal birth outcomes, caveat, small numbers. And Impact 2040 will evaluate PK and safety, and the PK, I think, is really critical in 45 pregnant women. This is a study in young South African youth, 12 to 24, given long-acting injectable CAB rilpivirine. They were either virally suppressed on treatment and switched. They had a raised viral load, and then they were resuppressed and switched, or they were ART naive. And you can see the study design there. At week 48, 96% were less than 50. In the 4 patients with viral load greater than 50, all had low-level viremia and resuppressed prior to the next injection. The majority of injection visits were within the window, only 2% without the window, 98% retention. No drug-related SAEs. Qualitative studies confirmed it was acceptable. So they concluded LA injectable ART is effective, acceptable, and feasible treatment for youth with HIV in South Africa. And now this is the CARE study, week 96 results. So this was a randomized trial to demonstrate the viral response of switching 512 virally suppressed adults to CAB rilpivirine given every 2 months compared to continuing oral standard of care in an African population managed with a public health approach and viral load every 6 months. And you can see the design here and the numbers randomized. 81% of the patients received all injections within the mandated window. 97% of all injections were within the window. HIV RNA less than 50 in 97% of CAB rilpivirine versus 97% of the oral standard of care. And in an intent to treat analysis, this was basically non-inferior. There were 4 CAB rilpivirine failures. Of the three with sequencing to be done, rilpivirine and CAB mutations were seen, but all three patients with failure resuppressed on dolutegravir. Grade 3 AEs related to study drug were seen in only 2%. Most of the AEs were injection site reactions, mainly grade 1 and 2, with only one leading to drug discontinuation. Patient satisfaction was much greater with injectable treatment compared to oral treatment. So they concluded injection long-acting treatment in an African population with sparse viral load monitoring and a high rate of prior NNRTI treatment had a 97% rate of viral suppression at week 96, non-inferior to oral treatment, good safety profile, greater increase in patient satisfaction, raising the potential role for LAART in Africa using a public health approach. And ending with a few short new formulations. So this is just a quick thing from PEPFAR, looking at CAB PrEP introduction into 110 clinics in 45 districts across several countries, shown here in 2024, and they used PEPFAR MER data. So you can see that over 6,600 people started CAB-LA PrEP between February and September 2024, with a twofold increase in the last quarter. Of those eligible for a second dose, 75% returned after 1 month, so on time to receive their dose. So these were promising data on implementation of CAB-LA PrEP in low and middle income countries, and I don't know what we're going to see given the current political situation. So this was a study, Prepared to Choose study in South Africa, that enrolled young people 15 to 29, and they used informed choice counseling, offering oral PrEP or CAB-LA with the option to switch. And between February and August, 57 pregnant women or breastfeeding women were enrolled and offered PrEP. So 44% were pregnant, 56% were lactating, 81% were PrEP naive, and you can see 84% of the pregnant and breastfeeding women chose CAB-LA at enrollment. This looks at an acceptability survey. 96% said that they were very likely to continue the CAB-LA. Many of them had prior injection experience for contraceptives. There was a discussion about the dapivirine ring, although it wasn't offered, and the main take here was that the young girls were very unlikely to want to use the dapivirine ring. Future preferences, most women said that they preferred a PrEP method that was injectable and that would last 6 months or longer. So pregnant and breastfeeding young women had a high preference and uptake of CAB-LA over oral PrEP with high acceptability, unlikely to use the dapivirine ring, and they preferred even more long-acting injectable PrEP methods like lenacapavir. Which brings us to lenacapavir. So this was an analysis of PURPOSE that just specifically looked at the adolescent group. So 2 to 3% young adolescents were enrolled. We know there were 0 infections in the study, so 0 infections in the adolescents. They looked at trough levels in adolescents and adults. There was no difference. They looked at adverse events that were basically similar between adolescents and adults. As I said, no HIV seroconversion. So basically, they conclude that you can extrapolate efficacy in adults to efficacy in adolescents. I think this may be the last one. This is looking at a once-yearly lenacapavir formulation. So they looked at PK and safety of a single 5,000 milligram IM dose of 2 different len formulations in 40 adults. So this compares levels in once-yearly len with the green versus twice-yearly len, as in PURPOSE, in the pink. And looks at the 2 different formulations, and you can see that the green shows that the levels with once-yearly len were higher than twice-yearly len over 56 weeks. Most adverse events were mild to moderate, no grade 4, and most were related to injection pain, which decreased over time. This was the last one. This is a multi-purpose implant. So this was an animal study that was evaluating the PK of an in situ forming implant containing cabotegravir and DMPA that were given to mice, and they looked at plasma levels. So cabotegravir levels in blue remained above the 4 times PaIC90 for 210 days. MPA levels stayed therapeutic for 180 days, but below quantification by day 210. Following implant removal, so that this is now removed, they could take it all out, undetectable MPA at day 1 and within 2 to 3 weeks for cabotegravir. So no tail here because you take it out, and no evidence of local or systemic toxicity. So it's the first study looking at a once-a-year preparation, and most importantly here, that you could become undetectable after implant removal, no PK tail. So the potential for a discrete and reversible multiple prevention technology option for women and girls. Yes, and that's it. Thank you.
Thank you so much, Lynn. This was really, really amazing. It was really, what an incredible presentation. I really can't think of having learned more in the past year and in the past few years of what you've talked about for pregnancy regarding PrEP, resistance, co-infections, new modalities, long-acting injectables, implementation trials. So thank you so much. I want to tell everyone to post. We may have time for at least one question if you have any, although I'm also going to share with everyone that Lynn has been kind enough to offer to share her presentation with everyone, not only this one, but also an expanded version that includes the pediatric component. So that will be available after this. And I just want to thank you. I want to make a few closing remarks, which are a couple of save the dates. The next webinar will be on June 11th at this time at noon, and there will be an announcement shared with everyone. We also have a save the date reminder for our biannual HIV and Women Inter-CFAR HIV Symposium, which will be on November 13th, and there will be more to come, and it will be a full day symposium focused on HIV and women. And I also want to remind everyone that the webinar, as well as prior webinars and future announcements, will be posted in the website and available to everyone. So thank you so much. I just see lots of thank you in the chat. I'm sure the questions will be coming after this to you, and really really wonderful to have you today, Lynn. Thank you everyone for joining.
Bye everybody. Be safe.
Thanks, Lynn.